Hello, my name is Robert Chapman. I'm the Medical Director of Lakeland Volunteers in Medicine, and I think that it's great that you are discussing health policy, quality, and assessment of outcomes in this course. After all, your generation will be forced to deal with the consequences of our decades of profligate spending and the deficits that we have engendered. Perhaps some of you are sanguine about the status of healthcare in our country. After all, we have some of the best medical centers in the world. For example, right down the road we have Moffitt Cancer Center, one of the top comprehensive cancer centers in the world. Mayo Clinic in Rochester, Minnesota, with a satellite right here in Florida, is unsurpassed in its ability to make difficult diagnoses. The United States leads the world in medical research, as well as drug and device development. The Center for Disease Control in Atlanta is world-renowned for its ability to handle epidemics. We have more Nobel laureates than by far any other nation. And our medical journals, such as the New England Journal of Medicine, are revered, and researchers all over the world strive to get an article accepted there. Indeed, if any of us came down with a serious illness, we could do no better than to receive treatment in a top-notch American facility. Yet, in quality comparisons compared to other developed countries, we fail miserably. The Commonwealth Fund has annually compared high-income countries on a variety of health statistics, such as life expectancy, infant mortality, access to care, and administrative efficiency. As compared to 10 other major high-income nations, such as Canada, France, Germany, England, Japan, and Australia, and others, the United States has finished dead last since 2004. Our performance is certainly not a reflection of spending on health care. The cost of medical care in the United States, whether looked at as a percentage of gross domestic product or per capita expenditure, is at least 50% greater than any other country studied. Thus, we spend half again as much as any other country on health care, and yet rank last in statistics of medical outcomes. Health care costs consume about 18% of our federal budget and are progressing on an unsustainable upward trajectory. How can this possibly be? On the cost side, the reasons are not hard to fathom. My experience, much more than my degree in psychology and my degree in medicine, have taught me that to predict behavior, one needs to evaluate incentives. Most of medical care in the United States is still paid for on a fee-for-service model. This means that the more the physician does for the patient, the more the physician is paid. In addition, medical procedures are paid for exorbitantly as compared to office visits. The patient not only has no idea what the cost of a medical encounter will be, but also, if well insured, has no concern since insurance will cover it. Thus, much of our medical care is paid for by other people's money. It is as if one goes to the car dealer to purchase the best car possible and only has to pay 20% or less of the cost. It's no surprise that you end up with a $100,000 Tesla. Also, in our culture, each physician tries to act in the best interest of his or her individual patient, often without regard to the cost to society. We are very reluctant to ration health care. In my experience, most physicians do not hesitate to prescribe very expensive medication when an inexpensive substitute would do just as well. There is no incentive to do otherwise. Furthermore, the pricing for care in our hospitals is so complex that neither the providers nor the patient have any idea what the cost of hospitalization will be. Many other factors add to cost. Pharmaceutical companies and device manufacturers price their products according to what the market will bear. Medicare does not negotiate drug prices. Thus, the same pill will cost much more in the United States than in any other country. Professional liability costs in the United States by far surpass those of other countries as well. Juries, often with no scientific medical background, try to assess whether a provider or medical institution met the standard of care. And if they didn't, it can cost millions. Okay, we discussed cost, but why are outcomes so poor? I think there are two major considerations: behavior and access. It is estimated that about 40% of variation in the incidence of premature death in a population is related to behavior as opposed to the quality of medical care, which accounts for only about 10% of the variation. Genetics, environmental exposures, and our social circumstances account for the remainder. Interestingly, the United States does well in the most important behavioral variable, smoking, with an adult smoking rate of 15%, lower than almost every European country. However, we lead the league in obesity and its consequences such as diabetes and increased risk of heart disease. We are also number one in gun violence and drug abuse. There have been some surprising statistics which have recently been published. For the first time in decades, life expectancy of white males in the United States has declined, which has been attributed to the epidemic of drug, particularly opiate abuse. In addition, deaths in our country due to motor vehicle accidents for the first time in decades increased year to year, probably due to texting. The other major contributing factor to our less than stellar outcomes is lack of affordable access to medical care for many. Although the number of uninsured in the United States decreased from about 45 million to 27 million with the implementation of the Affordable Care Act, that is Obamacare, we still, unlike other top-performing countries, fall short of universal coverage. In addition, many states, including Florida, have not accepted Medicaid expansion. Ironically, our uninsured patients who cannot afford to pay are charged retail rates for medical services rather than rates negotiated by insurance companies. Hence, most receive almost no preventive care and are forced to rely on urgent cares and emergency rooms whenever they get sick, often delaying care that could be much more efficiently and effectively been rendered earlier. In brief, what can be done? I hope that all of you will ponder solutions in this course, since your generation will be bearing the cost of our medical deficit spending. As a start, one needs to consider our employer-based fee-for-service payment system, which leads to little incentive to improve quality and perverse incentives to add cost. We need to consider the imbalance we have in the United States, which emphasizes specialty care and procedures versus primary care and prevention. We need to consider how to protect the patient from true medical negligence rather than adjudicating malpractice cases through an expensive jury system. We need to make pricing more transparent and assess the benefit to the patient versus the cost to society of ever more expensive and technologically advanced procedures and drugs. More importantly, we need to improve medical access so we are not providing the wondrous state-of-the-art medicine that we can provide to some, but not to others who have no insurance. Lastly, we have been very successful as a country in decreasing smoking rates, although we still have a ways to go. We need to muster similar resolve in solving other behavioral issues like obesity, inactivity, gun violence, and substance abuse. I trust that during this course you will have the opportunity to formulate your own understanding of our very complex health system and how it may be improved. Thank you for the opportunity to speak to you.